No, read what I wrote, I'm a bestseller. Yeah, reach for my goals, hit it dead center. Hit it dead center. Bullseye, hit it the most, is no misses. Something like fish in a barrel, it's no different. Blindfold on me, I still got the most vision. Trendsetter total.
In general, when the crusty or the scaly pets come to us, that's quite a challenging case, and we always feel like that something else is going to be happening with this case, and it could not be the normal allergies, it could not be the normal bacterial infections, and we always think up about the something very like unusual thing. But let me give you a brief idea that most of the times what we think about is, or very simple thing is happening with the patient, which we have to work up on, and these crust and scale goes. So I'll try to briefly explain like what should be followed. Hopefully by the end of the topic we'll come to know like what steps should be followed whenever these kind of patients comes to us, so that we can help in treating these patients and comforting these patients. So if I talk about the crust and scales, 90% of the cases, these crust and scale are the secondary lesions. So whenever you are going to see any derma consultation, one thing you must be very aware about is what are the lesions, like skin lesions, what are the primary lesions, what are the secondary lesions. This you have to like learn, this you have to memorize. It's not, there is no shortcut for that. Okay. And once you're able to differentiate between the primary lesions and the secondary lesions, that will help you to like move ahead with that case. So these crust and scale in 90% of the cases are the secondary lesions. That means they are happening because of either the remnant of the primary lesions, or they are happening as a result of some artifact, or some kind of trauma, or any blood discharge is coming and then it is getting stuck and then the crust are forms. So basically these are the, they always happen in case of the secondary form. Okay. So very few diseases are there where they are actually the primary lesions, like for example the seborrheas, which we'll talk about later. So crust is basically any like dried layer, like for example if earlier pustular lesions were there, after that the discharge which get stick over that area forms a crust at that particular area. And the scales, if I talk about, is basically a dandruff, like how we shed the dandruff. So there are dry scales, there are adhered scales. So yeah, so the one thing which should come to your mind is whenever a case comes is ki whether these scales and whether these lesions, crusty and scaly, these are primary or secondary. Okay. So whenever these cases come to me, my first thing which comes to my mind, or the some questions which come to my mind, is that along with these scales and along with these seborrhea thing, am I able to look the primary lesions? Am I able to see the pustules? Am I able to see the papular lesions on the body? And another thing is that dog is pruritic, or is that dog non-pruritic? What are the actual distribution of the lesions? Which body parts are actually affected? And what is the age of that particular dog? What is the breed of that particular dog? So these questions are very important. So if like by tomorrow you get a photograph from some owner and they are just telling you to diagnose the case without such kind of questions, it's very difficult. And I like, my suggestion is to never go for the diagnosis before knowing the proper history. So there should be always a good questionnaire with you. And like after a questionnaire, like you can actually make a list of a differentials which will help you in concluding that particular case to a limited number of differentials. Otherwise the list is quite vast, so your questionnaire should always be with you so that you can differentiate the thing. Okay. So like for example, a crusty case, if comes to you, or if comes to me, like one of the main thing which comes to my mind is like whether that dog is having any pustular thing or papular thing going on underlying the body, and my mind or my eyes couldn't able to see because now it is so bad that the primary lesions I can't see, you know? So always I try to rule out the pustular diseases, then some metabolic diseases. And since I told you that 90% of the cases, the pustular thing come into the picture. So I always try to rule out all the causes of the pustular diseases. And as we know, because pustule itself is a primary lesion, and these crusts which are forming are basically a secondary to those primary pustule. Okay. So pustule when formed, we know there are follicular pustules, there are non-follicular pustules, and their uh, how they look is very different. Their picture is very different, how they present. And it's okay if you don't know like how the follicular things look or how the non-follicular looks. The moment you start seeing more cases, you will become more familiarized, and uh, there is no, I would say, like harm or shame in searching or like googling the things how these things look. Okay. So whenever I see like, okay, follicular type of pattern is there, follicular pustules are there, then only three differentials come to my mind. That is Demodex, dermatophyte, and staph. And yeah, first I try to look for that with the very basic test which is available everywhere, and which you can do like a bedside test. They doesn't like need big expenditure and big investment. So non-follicular basically involves every other thing, like the, for example, autoimmune diseases, the pemphigus, the ectoparasites infection, in some cases of the food allergies, sometimes in case of the impetigos, contact allergies. So yeah, slowly I rule everything out. And when I talk about the follicular pustular diseases, among them, the pyoderma is one of the biggest cause, and particularly the staphylococcus pyoderma. And now, like for example, we know it's pustular. Now we know it's follicular. Now we know it is pyoderma. Then pyoderma also we know, like in almost 100% of the cases, pyoderma is secondary. Primary pyodermas are very rare. Then I try to look for, okay, now my mind have diagnosed that, okay, the dog is having crusting and scaling thing. It is happening because of the pustular disease. It is happening because of the follicular pustules. Okay, it is happening because of the pyoderma. And this pyoderma is secondary to allergic diseases. Then I will try to focus on that. Okay, so that's the proper flow which you have to follow one by one to come to a conclusion. It's not like that you have seen a crust and scales and okay, this is a diagnosis. Otherwise you will end up having the flares again and again. Okay. So yeah, whenever I see a pyoderma, I immediately go for the cytologies, and just I have one thing in my hand. Okay, I know this thing is happening because of the pyoderma. Then I focus on the pyoderma. Okay. Likewise, the impetigos, like the small puppies which are having the crusty thing on the abdomen, and this happens because of the non-follicular pustules, and they happen because of the low immunity, and it just goes away. So if I'm seeing a crust, a deposition on the abdomen, and if I don't know like what these lesions are, or I don't know the age, I don't know the what is a pictorial description of that thing, then it is very difficult to diagnose. It's not like that you have seen a pustule on the abdomen and you assume that okay, this is a diagnosis. There are some conditions which you have to look up upon. There are some conditions which you have to be familiarized with. Then only you will be more confident in diagnosing the things. Okay. Likewise, in case of the puppy strangles, they get the whole like pustules or pus coming out from the skin, and the crust get deposits over everywhere. So yeah, so you like the case will come to you as a crusty thing only. But yes, if you know the age, if you know the location, okay, where this is happening, if you know, okay, this can be the differential for this, then you slowly move ahead with the thing. Okay, so in these all cases, the crust and scales are happening as a secondary to some other primary disease. Okay, in case of the pemphigus foliaceus, you will see like non-follicular pustules and erosion and ulcerations, which will ultimately form a crust over that particular area. And yeah, and if you know the age and if you go for the proper diagnosis, like on cytology you see very beautiful acantholytic cells, so that will help like give you an indication, and further on you can go for a biopsies to confirm that thing, and then finally you know, okay, okay, my case is that crust is happening because of this. Okay, in case of the contact allergy, sometimes papular pustular dermatitis, mostly papular thing happens and the erythema, and then the these papules when get healed, they start shedding in the form of the scales, and you end up having erythemas and scales. So that you have to rule out. And another thing which I also keep in my mind is that whenever these lesions are there, are these lesions pruritic or no? Because if the lesions are pruritic, then another picture comes to my mind, whether that pruritus is happening because of some infection, because of some parasitic thing, or bacterial infections, or malassezia infections, or allergies. And if pruritus is not there, then my differential list almost get little change. And it's not necessarily like the pruritus thing, like the another differentials I don't consider, but yes, like my top differentials get changed if this point or this clinical signs add into the picture. Yeah, so non if things are non-pruritic, then I would more think about the endocrine thing. I would more ask about what is the age, or what is happening, any other systemic sign going on, and the other metabolic things will come into the picture. Okay, for example, these small puppies having the scales into at the ear margins, and when I scrape, it came positive for sarcoptes, and that dog was not at all itchy. So there are some things which you always have to do. Like, for example, if you know it's a puppy, and what could be the other thing happening to the puppy if the scales are present at the ear? So just go for one scrape and see how things are going on. Okay. And likewise, in case of the hypothyroidism, such sometimes only the systemic signs are there, and along with that, a dull hair coat and the scales which are coming out. So yeah, that is also one of the differential for that. Or in case of the atopic dermatitis, in which the barriers are not good, or they keep on like shedding their superficial skin because the filaggrin protein is not there to hold that. So yeah, these all differentials should be considered in the mind when you are approaching toward the case of the crusting and scaling diseases. uh, and for all these things, like at the first glance, like whenever a case comes, apart from asking the full history and getting the full signalement, and right from the very beginning I asked like how the thing started, and if you have given any treatment, if that treatment was given, what was the effect, anything which has helped him so far, and is he on any flea preventions, is he on any ectoparasite prevention, okay, what medications he's on, that gives you a very vast picture of what is happening with that particular patient. And a few things which I always love to do in my patient is one, cytology, skin scraping, and I personally look for the cytology at my own, and I encourage you also, like every one of you, to see the cytology at your own. Slowly it is little like difficult to differentiate the artifacts with few things, and it's difficult to understand like what is going on, but I think when you see like 15 or 20 slides, like you become slowly become master of the cytology, and you know what is normal, what is abnormal, how bad is that case, or what is happening with that case. And sometimes if you are lucky enough, like for example, I got one case of the nodules over a dog, and when I took the FNSC, I could able to see the spores of the fungi, so that was quite rewarding for me. So that can happen with anybody. So if you start seeing the things at your own, that will give you a more confidence for a case, and you can make that flow diagram in your brain, like okay, this thing is ruled out. Now what should I do? Okay. And most of the time in a clinical practice, whenever you see a case, it is not like a direct presentation of a disease. Like for example, it won't be like, okay, elbows and ears are affected and the dog is very itchy, and straight away you say, okay, this is a sarcoptis. No, it doesn't happen like that. Most of the times when the case presented to you, it is all crust scale with the secondary infections, and you don't know what is underlying going on, but it's okay. I would suggest it's completely normal. So in that cases, what I do is, like, what I could see first, I treat that. Like for example, if on my impression smears I could see the malassezia is very bad, I could see the bacterial overgrowth, or if the active infection of the staph, I will try to treat that. Then after 1 week, I ask them to come again, and then I work on the diagnosis. Okay, let me work on what is going on. But before that, it is very difficult sometimes, and it happens with everybody. It is very normal thing. Okay, so yeah, if any case comes to you and you don't know what is going on, just do these tests, and whatever you see, first treat that. Then slowly move ahead. Okay, this thing is ruled out. Now whether this thing is primary or secondary, that I have to work upon. Okay. So 90% of the cases which you are going to see in your clinical practice is like these crusty and scales are always secondary to some other disease which is going on. It means in them, actually, the keratinization process is not affected. Okay. So before coming on to the primary keratinization disorders, keratinization means, like, for example, we know our skin has the different layers. Dog and cat skin has different layers. So it starts from the stratum basale, and slowly it moves forward and it moves to the stratum corneum, and slowly it's just shed off. Generally the shed off like happens, the turnover rate is of 3 weeks. After every 3 weeks they shed their external skin and the new skin come up. Okay, but the scales which shed off are so like tiny or so thin, like you won't able to see. But if anything happens, anything like, as in if there is a deficiency, if there is a genetic problem in the skin, or this keratinization process is affected, that is the production and the removal of the layer is affected, then in that case the visible scales are going to, like, you will going to see a visible scales which we call that as a scaly thing, or which we call as the dandruff which is coming on the dogs or cats. Okay, so these four steps, like, first is the actual keratin, the keratin protein which forms, and this keratin is like, on depending upon the location, whether this keratin is present at the paws, whether this keratin is present around the lips, around the nose, it has a different composition. Let's not go deep into that. Another step is the formation of the keratohyalin granules, basically. So these granules from where the filaggrin protein forms, which help in binding of the keratinocytes. Then the third one is the formation of the cell envelope, and the fourth one, the important step, is the formation of the granules, lipid granules, sorry, lamellar granules, which releases the lipids. So if I talk about the lipids basically are those which ultimately changes into the ceramides, which ultimately changes into the essential fatty acids, to make the skin hydrated. So if anything is happening to this process, basically your hydration status, your skin barriers are lost, and which ultimately, like, the keratinocytes will shed off and you are going to see these things. Okay, so this process actually happens in the primary keratinization disorders. In secondary keratinization disorders, something else is causing this thing. Okay, the body is reacting towards that. It's not like actual keratinization thing which is affected. Okay. So yeah, the I talk about already the filaggrin and the lamellar bodies, which is important. Another thing is natural moisturizing factors. This is basically a degradation product of the filaggrin protein, and it helps in maintaining of the pH. So if there is no filaggrin, there is no NF. Um, then depending upon these things, like, there are some diseases. For example, if a filaggrin protein is mutated or altered, we have a disease called ichthyosis or atopic dermatitis. And if this keratinocyte rate production is very high, then the normal dog, then we have the seborrhea, the primary seborrhea, in which the like ideally it is 3 weeks, but in these dogs it can be as quick as a 7 days. Okay, so that's why it just comes so rapidly. Along with that, there are other changes also. That's why the dogs have the secondary conditions. So, what you should look for if you are seeing a primary keratinization disorder? First thing is they start from the very young age. Most of them start from the very young age, but there are some which develop, which has an adult onset also. But most of them develop at the very, if I talk about the young age, it means the puppyhood, even less than 6 months of age, they started having this problem. These diseases are genetically inherited. And one of the key factor which these diseases have is that these lesions are non-pruritic. Okay, until and unless they are infected by the secondary infections, there are only scales which are coming out, but there won't be any pruritus. Okay, and there won't be any primary lesion, because in this the scales itself act as a primary lesion. Okay, so you are not going to see any pustule, you are not going to see any papule, so the leftover epidermal colorate is forming the scales. No, the scale itself coming act as a primary lesion. Okay, so these are 3 4 things which you should always keep in your mind while approaching towards the, or while thinking about a case as a primary keratinization disorder. So first condition which I talk about is a primary seborrhea. So this condition is mainly breed predisposed and commonly seen in case of the Cocker Spaniels and the Springer Spaniels, but have been seen in the Labradors, Doberman, German Shepherd, Dachshunds, and Schnauzers. So there are two types of seborrhea. One is the dry form, one is a wet form, Seborrhea oleosa and Seborrhea sicca. So I already told you that the turnover rate of the skin basically increases in these cases. So whenever such kind of cases presented to you, what happen is when they are like, since the time they have born, their hair coat is very rough. It's not like a normal puppy hair coat, and initially people ignore, and initially we think like something else is going on, probably the dog is runt or he have not got the proper nutrition. But no, as he like increases, as the age increases, slowly you will start seeing the scales which are coming out. All the other signs of the seborrhea started developing, like they have the very bad cereminous otitis. Okay, which is not pruritic until unless it is infected. Along with that, these lesions mainly happen at the fold areas, like the axillas, like the inguinal areas. Along with that, in the interdigital spaces, under the neck, even at the lip commissure. So these are the main areas where it is commonly seen. So and one of the key differential of this particular disease from the allergic dermatitis is that in these cases, these scales come first, followed by a pruritus. But in case of the allergic diseases, pruritus come first, followed by the secondary scales because of the infections and everything. Okay. And so if 1 year, less than 1 year old puppy is having a problem of the shedding scales, then only for few differentials are left with you. Like in puppies, what could cause the pruritus and the scale, if you are actually doubtful, like what is happening, either some ectoparasite infection or some kind of nutritional deficiencies like zinc deficiency which is going on, or in case of the food allergies, rest differentials are very less. So mainly if you have ruled out major things, then and the breed is predisposed to that, then the other thing come into your mind should be a primary keratinization disorder. Okay, so it is not like that you can always be wrong, you can be right also if you have ruled out everything. Okay, then and you know the fact, okay, these sites are affected, you know the fact, okay, this breed is prone to that, and you know the fact since the puppyhood this thing has been going on. It's not like he got this when he was 2 years old, like in case of the allergies, when he was 3 years old. So then you could able to differentiate. And these are the beautiful pictures from the book Muller and Kirk. So as you can see how bad the otitis is, scales which are coming out. And along with that, since the keratinization rate is so high, So you can see the hyperkeratosis over the paws, even on the nails, and interdigital spaces are becoming red. Sebum is oozing out from that. Okay, so this is a presentation. So if I talk about the diagnosis, generally these diseases are, if you have excluded everything and by concluding the clinical signs and everything, you diagnose these cases. There is no as such definitive test for that. Okay, in skin this is a problem. Like, it's not like you are going to do one test and people are telling you, oh, this is a disease. No, you have to relate everything. You have to go step by step, rule out everything, and then conclude the thing. Okay, so when it comes to a management of a seborrheic patient, we should know about, like, because we know like these patients can never become normal, because that's the problem they are born with. You can only manage these dogs. You can never like completely make this dog normal. Okay, so one are keratolytic agents and one are keratoplastic agents. Keratolytic means that they will help in the softening of the stratum corneum and the removal of the scales. Keratoplastic mean these agents try their best to renormalize the epithelialization. Okay, renormalize the keratinization process. Okay, and there are different products, like for example selenium sulfide, sulfur, salicylic acid, and everyone has a different level of uh, keratoplastic property, keratolytic property, degreasing property. So depending upon what your patient need, you have to decide, okay, which shampoo is required in my patient, whether my patient along with this like seborrheic, anti-seborrheic shampoos or keratoplastic shampoos require the follicular flushing also, or whether my patient need antibacterial shampoos also. So I always make a recipe of the shampoos, like one time bathe with that, second time bathe with that, or if you are going for the two times or three times bathing in a week, then I go like, okay, this shampoo has to be there, but along with that I have to manage infections also. I have to prescribe antifungal, I have to prescribe antibacterial. But yes, for the keratoplastic thing, I have to prescribe a shampoo which has this salt also. So yeah, I always prefer to manage such kind of cases with the topical therapies, because how long you are going to give the oral thing, because the moment you stop the oral thing, it is going to come back. So we have to be pretty much normal with the topical therapies, like how these are going to help. And in this also, like for example, ability to remove scale, some agents have the more ability, some agents have less ability. So yes, selenium sulfide, for example, sulfur, salicylic, these are good in removing scales. Benzoyl peroxide is good as a degreasing or follicular flushing. Chlorhexidine is more like an antibacterial and also effect against the antifungal. But yeah, so depending upon what your patient need, you have to decide. And these are some like Indian shampoos which are available, and which I use if such kind of cases come to me, because they have these salts. So yeah, you can use that. Another thing which we have to keep in our mind is that whenever we are using such kind of shampoos, they are extremely drying on the surface, okay, on the stratum corneum, on the skin. And if the skin is extremely dry, and already they have the problem of epidermal barriers, so you have to take care of those barriers. Okay, so some textbooks or in some people, like they prescribe emollients which make the thin skin soft, and moisturizers which are actually like they absorb the water content and make the skin smooth. So these can be used after bathing. And if emollient mean oil, like for example, some people use castor oil, some people use peanut oils. Okay, and there are good preparations now available in the market in the form of the spot-ons, like for example those having the sphingolipids, those having the ceramides, that can also be used. And like propylene glycol preparation, you can make 1:1. It's easily available on the Amazon. You can make a spray of that, and after bathing you can spray on those areas so that the body remain hydrated. But yeah, good preparations are available in the market also, that also you can use. So always like keep a check on that. So systemic drugs only should be applied if like the topical things are not working in a case. So people try with the retinoids sometimes because it helps in the keratinization process. But yeah, all of the side effects should be taken care into account, and that can be used momentarily, but followed by that, like for more time, it should be like not used. But yeah, if you have started, then it will take a month at least to show its proper action. Okay. Some people use steroids. Steroids also give very momentary relief, because of its action, basically it caused the atrophy of the skin, and it just reduced the keratinization rate, but that's very momentarily. So yes, for few days you can use, but better is to manage the cases topically, and along with that you have to manage otitis externa with the proper air cleansers and everything. Some people have seen improvement with these cytotoxic agents also, like cyclosporin. But yeah, depending upon the case, you have to make a prescription. And like I always start from very basic and then slowly move if my patient is not responding to a case. Okay. Don't directly jump just to get a results in 1 or 2 days, because if that thing is not going to work, you end up having nothing. So like start from the very basic and then see how things are going to work. Another condition which come into the picture is vitamin A responsive dermatosis. This is not actually a deficiency of vitamin A. This is basically the coccus spaniels or the labs which are having these seborrheic diseases, but now their diseases are refractory to the topical treatment, so they have to be managed with the systemic medications. That is vitamin D. The moment you give vitamin A, they become like much better. Okay. So the features which you are going to see in such kind of dogs is basically the follicular plugging, the surface fronds, and ceruminous otitis, almost similar to like that of seborrhea. But follicular plugging is something which is more evidently seen in this case because the condition has become worse. Sorry. So and the differentials for the follicular plugging is also quite limited. So you can rule that thing out, like the sebaceous adenitis, follicular dysplasias, and the Cushing disease. If everything is ruled out, then ideally its diagnosis is response to the treatment. You have to start a patient with the vitamin A and see how things are improving. And generally, the dose is 10,000 IU once a day with fatty meals, and complete remission generally takes 1.5 to 2 months. Okay. So these are the pictures again from the good textbook. So you can see the comedone formation and the fronds which are there on the edge of the ear pinna. Along with that, the ceruminous otitis. Another keratinization disorder, uh, which is seen in these Westies, the West Highland White Terriers, is epidermal dysplasia. There is a debate about this particular condition, honestly, because earlier it was thought that the epidermal dysplasia has happened, and that's why the patient is getting the secondary malassezia, secondary infections. But later on, after like few people have seen when they treat the malassesias, the patient is becoming completely normal. Even this dysplasia has gone. So what came to the not conclusion, still it's a debate only. So what they have noticed is like probably these patients are hypersensitive to malassezia, and because of that hypersensitivity, these dysplasias are happening, and the moment you treat the malassezia, they become completely normal. So basically you have to uh, in these manage the uh, infection of the malassezia to control the hypersensitivity reaction of that. And yeah, slowly if the malassezia is under control, the dog infection is under control. So basically this happens with this dog because you can't get rid of this thing. Don't know how to remove this. Someone has me. uh, it's okay, leave. Another disease is ichthyosis. To be honest, I have never seen ichthyosis puppy. I've only read this in literature, but I am very keen to see this case in real life, probably one day. So This is a fish scale disease. It's actual congenital primary keratinization disorder, which has the autosomal recessive mode of inheritance and which is particularly seen in case of the golden retriever puppies, but yes, reported in the other breeds also. So what happened is that it happens because of the filaggrin protein uh, problem. So or sometimes they don't have those cells which releases the filaggrin protein. Okay, so the skin, underlying belly skin, is so dry, the scales are so stuck to that, and when you remove the scale, it just keep on like come as a peels. Okay, along with that, the cereminous otitis and everything is there. So as you can see, these are textbook images because I have never seen this case. Like how and like you can see these cases when the puppies are born. Okay, some people claim like they have seen when patient grow, it become more like visible. But yeah, puppies have problem or sometimes only hyperpigmentation at the belly area, which slowly increases. Okay. uh, Generally the biopsy only helps you. There is no as such a definitive feature which you are going to see in the biopsy, but yeah, that helps you like orthokeratotic hyperkeratosis and such kind of features, like whole the skin layer is somewhat affected, that like I think pathologist will explain better. But for the golden retrievers, a genetic testing is available. The buccal mucosa sample needs to be buccal swab. We have to send, and they just look for this protein, and finally you can diagnose and you can ask the breeders to stop the breeding of that particular animal. And management is same. All the keratinization disorders needs to be managed in a similar way. You can use the humectant mode, you can use the moisturizers mode to keep the skin more hydrated. Okay, along with that, some people use the retinoic acid. uh, for example, I heard Dr. Rosanna, she used this itretinate, but I have used once isotretinoin, but I don't have any knowledge of this second drug. Another condition, which is, I think, I have seen this multiple times, so I think this is commonly seen, is a feline idiopathic seborrhea, that is dirty face syndrome. This condition is basically idiopathic. Nobody knows like why this happens, and it happens particularly in Persian breeds, young Persian breeds, that the ocular, peri nasal, like these lesions, like the skin around that particular area is moist, scales do come and it become infected, and it is generally known as a dirty face syndrome. But yes, the breed and the presentation itself is the diagnosis for that. There is no as such the specific test which you can do, but you can always look for the secondary infections like the cytology, which will help you in knowing like what infection along with that going on, because the yeast are very common with that, and that you have to manage. Okay, so yeah, you can manage this with the topical ointments, or along with that the sometimes the oral azoles to manage the yeast. Another thing are the chin acne. There are this is seen in both the like species, in the cats, in the dogs. In the dogs, particularly, the chin acne is like I have seen in case of the short coated breeds, and because of the short coated breeds, probably their hair act as the bristles, or they rub their skin too much, and that happens like the pustule, and then later on a fruncle is formed, and then later on this turn into a big acne, or sometimes even the cellulitis thing happens. It is more infectious in case of the dogs, but when I talk about the cats, in those this is actually a keratinization disorder, and in them these glands, like they form more comedons, and sometimes it become infected, and then sometimes it causes the infection. So initially, like before turning into the acne, in them the comedons are accumulation and more in these kind of cats at the chin area, which often like misinterpret as the flea dirt, but this is actually a comedons which anytime get infected. But yeah, the topical anti-seborrheic shampoos are really good for that. For cat, the only few like shampoos or products can be used, like tar shampoos are not recommended in them. So yeah, The topical, even tretinoin creams can be used, mupirocin ointments can be used. That will help in management of that. Or normal, like 2 to 3 times the washing of that particular area will help you in keeping that thing clean. Then sebaceous adenitis, the another, some people diagnose it under the keratinization disorder. Some people like discuss this separately. Um, so sebaceous adenitis, there are glands inside the skin, okay, and these are the sebaceous glands which secrete sebum, okay. So because of any like immune mediated condition or keratinization disorder, the inflammation of these glands happen, and these glands slowly, like destruction of the glands started happening, okay, which is very common in case of the akitas, like commonly seen in case of the akitas, German shepherd, chow chow, dachshunds, and retrievers. I have seen in case of the akita and a retriever, okay. And the presentation in long coated breeds and short coated breed is completely different. In long coated breed, it mainly like a follicular cast. You will see a secondary infection, alopecias, mo, and proper scale formation. In short coated breed, it will form like a proper moth eaten appearance that you generally see in case of the pyodermas. Okay, so that often get misdiagnosed, but yeah, biopsy helps you a lot in diagnosis of that. Like for example, this I saw in case of the akita, where the the scales were completely formed, all the like hair particles, they were stuck with the keratin, and whenever you do the trichography, you could able to see the follicular cast. And if you do the biopsies, you can see the proper inflammation or the granuloma formation around the sebaceous glands. And sometimes the cases are so severe that when you take the biopsies, there are no sebaceous glands. So yeah, so management again with the same keratolytic shampoos and the rinses. Some people in these, because the sebastans is so stuck with the hair. So what they do is like they apply a baby oil massages, like 1:1 ratio, and then after 3-4 hours just remove that oil with the good keratolytic or keratoplastic shampoo. And even vitamin A also helps in the renormalizing this thing. But general management, topical management is more helpful. And cyclosporin has also seen a good results, but it will help only when there is an inflammation actually happening around the sebaceous glands. When there are no sebaceous glands, cyclosporin is not going to help. In that case, you have to manage more topically or with the retinoids. Another condition is zinc responsive dermatosis. Zinc is essential part of the keratinization process. So there are basically two types. One is syndrome 1 and one is syndrome 2. In syndrome 1, basically, like some breeds are prone to this condition. For example, the huskies are mainly prone. What happens is that their gut won't able to absorb the zinc, though if a diet is complete in zinc, their gut has like it has a problem in absorbing the zinc, basically, in short. Okay, and what ultimately starts happening is you will see a scaling and alopecia and crusting around the eyes, on the nasal areas, around the chin, sometimes on the paw pads, ears, and the hair coat becomes very dull. So in this, you have to provide the extra supplementation of the zinc. And elemental zinc, if you are giving, it should be like 2 to 3 mg per kg, and zinc sulfate, if you are giving, that is 10 mg per kg. And generally for quite long period you have to give. And if they have a problem, then it means that they need lifelong supplementation of the zinc. Sometimes even if you are providing zinc also, then also the things won't recover. So people like try with a very low dose of the steroids that also help in increasing the absorption of the zinc. And sometimes with the omega 3s also, like oral omega 3s, it helps a lot. And it has been seen that when in these drugs any stressful event happens, the absorption further decreases. Like for example, if it's happening with the female, then it is seen that like whenever they come in a heat, their absorption like decreases a lot and they started showing the signs. So in that, it is recommended to always go for a OBH. It helps. Okay. And second type is actually seen in a growing puppies when you are giving a diet which is a deficient in zinc. Okay. So, or you are giving a diet which is high in phytates or which is high in another minerals which are which is competing with the zinc absorption. Okay. Like a diet very high in calcium will compete with zinc. So in that, yeah, like just provide a good zinc diet, they become completely normal. For the zinc responsive dermatosis, the biopsy is actually very good diagnosis. You will see a perivascular dermatitis. You will like perivascular dermatitis. It means that there is a nucleated keratinocytes, and sometimes even it comes on the cytology also. So that will give you an indication like, okay, something metabolic thing is going on and I should go for a biopsy, or this could be this thing, because nucleated keratinocytes generally don't come. Okay. Another condition is a tail gland seborrhea. I think this most of us have seen in our daily practice, which is known as a stud tail. So this is a like oval spot which forms on the dorsal of the tail, and that particular area of the tail is full of glands like sebaceous glands, hepatoid glands, and these glands are under the control of the androgens. So whenever the androgens are releasing more, these glands become completely active and they start releasing its secretions, and more sebum, more thing get deposited over there, and ultimately a keratinization thing happens. Even in case of the cats also, they have these glands. So if they are like you have confined them into tight cages, and they couldn't able to groom that particular area, then you can see that evidently. Okay, so it is said that if you go for the castration of these dogs, it helps a lot, and it will take at least 2 months to decrease the size of these glands. But even in the uncastrated dogs also this has been reported. So in these dogs generally it is said that if an in an uncastrated sorry castrated dog this has been seen, then one should go for the biopsy to rule out the tumors, and what one should go and look for the adrenals properly, because adrenal glands also control these uh, secretions. So adrenal carcinomas and disorders should be ruled out properly in these cases. And another, the cleaning thing and everything should be done, like how like that particular area you can wash with the shampoos, you can clip that area so that it's more clean, and generally it remain confined to that area only. Those like proper cleaning and topical therapies help a lot. So yeah, those were the conditions which were actually primary keratinization disorders. So some of the primary keratinization disorders we like see in a general practice, but like some of them, for example, the seborrhea, the primary seborrhea. Na? So these things, like before concluding, you should always rule out the secondary infection. So that is my conclusion only. Like most of the crust and scales which you are going to see in a clinical practice are secondarily infected cases, and that should always be ruled out. Okay. And if you feel like, okay, you have ruled out all the things, every differential has been considered, and this case is falling under the category and all the clinical signs, even if the biopsy is supportive, you have done the biopsy only, then you are only left with the primary keratinization disorder, then you can manage that case as a primary keratinization disorder. Okay. And there is a high possibility of these seborrhea or the keratinization disorders getting secondarily infected. So in that case, the secondary infections. Okay. So many students used to ask me, like, what are my sources, from where I read or from where I started? Because like 8 years back when I started working on dermatology, because I got research on dermatology. So this was my book from where I started and from where I learned everything. And then slowly I started, I got a contact of Dr. Nagarajan sir, and then we got a WhatsApp group, and there we used to see the cases and everything, and then discuss, okay, what could be the thing. And slowly I started attending the sessions and the workshops and so many things. So but before going into the workshops, before going for the bigger things, my advice would always be to all the students, who are new into this thing is to make your like roots little strong. Like you should be little aware about like what are the clinical signs, okay, what is a description of like how to present a case, okay, what are the bacterial diseases, what are the fungal diseases, then only you can see, okay, this disease looks like this. If you don't know the like basics, है ना, like what are surface pyoderma, what are superficial pyoderma, what are deep pyodermas, then it is very difficult to understand what is actually going on. And now if you go for the workshops and everything also, like people will talk about their more the technical things, है ना. So just read 2 3 like first 3 chapters of this book. It will give you a lot of knowledge like how to start working on dermatology, and it's a bible of dermatology. I think if I hear the lectures of all the diplomates also, whatever they say, it's from this book only. I think it's very big thing to say, but I have seen like whatever they're saying, it is into this book. So this book is like really, I recommend everyone to just read. And yeah, then slowly so many things are available. And we are coming up with our fifth conference of the dermatology, which is going to happen in Kolkata. I, on behalf of IAVD, welcome all of you over there. So we can come, we can discuss, we can see the lectures, and you can read those 3 lectures first, and after that come and attend these lectures, and then yeah, we can discuss the cases. And this is the way like you learn the things. Even when I go, I also like attend their lectures, and I understand, oh, this is what I was doing was wrong, this is the correct way to do this, you know. So we all are students, so there's no shame, there is nothing, like you can ask anything, you can be a part of this association, and we have groups where we can discuss. So yeah, that's all from my side. Thank you for listening me patiently.
Thank you, Doctor, for such an insightful and practical session. I hope everybody would have have a lot of takeaways from your lecture. And like towards the end of the session, the floor is open for Q&A. I request all the doctors who have the questions, please unmute yourselves one by one and ask the questions. So that it's helpful for all the other fellow doctors as well. You can unmute yourself and ask the question, or you can write the questions in the chat box as well. We can pick it up from there.
Yeah,
I think we have one question there. I'll just read out.
yeah, I can see that chat box.
Okay, yeah.
Yeah, so her question is like how you approach towards the use of like corticosteroids and immunomodulating drugs, like in deciding how to manage the autoimmune disease. So honestly, it depends upon what autoimmune disease it is and how bad is that autoimmune disease is. Like for example, if it's a case of a DLE, like that the nose get affected, I would prefer to go for the topical steroids. I never even prefer to give oral steroids. If it's a case of a pemphigus and the whole body is infected, then my straightaway choice is to go for first steroids, and that to a immunosuppressive dose of the steroids. But that's my choice, you know, because my patients have responded to that case in such a way. Like some people I have seen are very much comfortable with the niacinamide and tetracycline preparations, and some people are comfortable with the cyclosporin itself. But that depends. Like the things which should be considered in a mind is what is a diagnosis, what is your case diagnosis, how bad that case is, and how bad the dog is suffering from that. And yeah, and like based on your experience. But yeah, diagnosis and this thing will help you in that. Another thing is how to differentiate between the bacterial and skin infection. uh, if I read this question, like one thing which is very very important is all the moth-eaten appearance dogs, like those circular alopecia patches, not all, basically 90% of dogs, okay, those circular patches which we immediately when we see and we say that, oh, this is a ringworm. No, it's not true. Even I used to say that. But the superficial bacterial folliculitis has very much similar appearance like the fungal, and in 90% of the cases it is a pyoderma, not a fungal disease, okay. So what I do is I always like take a impression smear of that and send a culture for the like a fungal culture of those scales to rule that out. And meanwhile, like I do the woods lamp also, but I never rely completely on that. If I am doubtful for any case, then I send that thing for a culture. But like, if you see the appearance, 80 to 90% of the cases are of pyoderma, which looks very similar with fungal diseases. Another question is, what is the general treatment for skin diseases? Skin itself is a big subject. Okay, so there is no as such general treatment. We have to read, we have to read, we have to dive into this ocean and slowly learn, like one by one. Even like, I was student 7 to 8 years back. I'm still student, but I learned through that book I told you, है ना? And after that, reading the lectures and so many things. So yeah, once you learn like, okay, hotspot need this treatment, okay, acne need this treatment, okay, superficial bacterial folliculitis need this treatment. But before knowing, if you don't know the disease, how you are going to treat, it's very difficult. Okay. Another is the role of sulfur ointment in the management of the seborrhea. I would say that if sulfur shampoos are available, because seborrhea, when happens, it happens on the whole of the body. And if you have diagnosed that, okay, this is a primary seborrhea and I have to manage with the shampoos, then in that case, shampoos are more like beneficial for that. But yeah, if like a particular point is there where the scales, which I have never seen, but if particular point is there which you want to treat, you can use the ointments. But I am more comfortable with shampoos. I barely use, except hotspots, I barely use ointments. I'm not comfortable using ointments. Agla is, yeah. Okay. Next question is, whenever a case comes to me, like, what is my diagnostic approach? Like, for example, a case comes to me, when I look from a distance, first I see, okay, which breed it is, okay, what are the lesions, like where these lesions are present. Then I put my questionnaire in front of the owner. Since how long this is present, what was the first initial presentation, what lesions were there, is there any seasonality which comes into the picture, how this all thing started, are you giving any treatment for that, and if you are giving treatment, is he responding to that? That will give you a lot of picture, है ना? Skin revolves around only 4 5 things, है ना? Bacterial, parasitic, fungal, autoimmune, and allergic. That you have to find, like, which is going on, or both are going on, or 3 things at a time are going on. Okay, that you have to decide. It is not like, okay, you have looked from the distance. Then slowly, how you do is like, first classify, okay, my patient is 3 months old and my patient is itchy. Okay, now you start seeing, okay, which part is itchy. Okay, my patient is itchy at the elbow part. Okay, my patient is itchy at the belly part. Okay, if it's just three months old, it's just a puppy, it's itchy, should a parasitic thing comes into my mind? Okay, if it's a parasitic, okay, should I go for a scrape, should I go for a flea combing? So these are the ways how we rule out, है ना? Ab now in 3 months old puppy, my mind won't go na, like, okay, this patient could have a cutaneous lymphoma, this patient could have uh what else, pemphigus, this patient could have like any like big disease. No, if like, start from very basic. Okay, this is a case, what can be the thing? Like, for example, once one case presented to me, and that was a fourth referral case, and it was happening like a puppy is keeping on like scratching, and they're like, we have used everything but we don't know, and it was just 2 months old puppy. Then I was also like that, oh god, there is no differential for that. If there are no parasites, like, why is itchy, why he is itchy 2 months old, but there is like, it's quite young for food allergy also, like, what is actually happening? Then when I looked very carefully, it was having a lice infestation. So this is the way how you come to know like what is actually happening with the case. Never rely on what previous person has do, like, do by yourself. What topical ointments are safe to use near the eye region? That depends for which purpose you are using. Generally, I don't give any ointments to apply near that area. Otherwise, neosporin ointment sometimes help if you apply near to the eyes. But why to give ointment near to the around the eyes? First, diagnose the condition. How does epidermal dysbiosis contribute to the persistence even after Yes, epidermal dysbiosis. It means that the topical, the flora is getting disturbed. See, if the flora is disturbed, dysbiosis has happened. Definitely, the scaling is going to happen, because those things will. Two things mainly predominantly cause this dysbiosis: malassezia and bacteria. They are going to cause the infection. So, what is causing that? It means definitely underlying something is there. Okay, like mostly in allergic dogs these things come into the picture. So if you are not addressing the allergy, these scales are not going to go away, though if you have used antibiotics also. So both the allergic management and the dysbiosis management have to go like simultaneously, concurrently, है ना? Otherwise if you control one thing, the scales will keep on coming, because the underlying thing is like shedding up. Okay. For the treatment of pyoderma, if any owner has used third generation cephalosporin, then what should a vet opt? Okay. If yeah, here also, like I have seen a patients who directly come up with the use of the linazolid or sometimes very high antibiotics I have seen. But and I'm not lying on that part. In my practice, I have never used third generation cephalosporin. I have never gone beyond a cephalexin, honestly, until or unless it's a case of a methylene resistance pseudo intermediates. I have never used that. Cephalexin helped really well. And that is also like my last resort, means the oral antibiotic. First, I always try to manage with the topicals, because chlorhexidine shampoos work really well. Okay, so I try with that. And if they are using third generation antibiotic, it's not necessarily you have to continue. You can just stop that and just manage with the topicals. If topicals stop working or topical is not showing effect in 3 weeks, then I shift a patient to that. But I think it's more about like challenging on the basis of the client also, like how to convince a client, and that trick we have to learn. And if the client is like convinced, then they follow like whatever you say. Okay. uh, so yeah, I don't continue these medications when they come. Keratitis, sicca management, dry flakes management, I think you are talking about. It's same like how I mentioned in case of the seborrhea, like with the shampoos and everything. Ma'am, how to differentiate between the superficial and deep pyoderma on clinical presentation? Deep pyodermas are very bad, you know, and superficial mean only the first layer of the skin is infected. Deep pyodermas mean it has gone into the subcut level, okay, or the deeper layer of the skins. You can see it like right from the distance. The pus will start oozing out, and sometimes even the systemic signs are also there if it has turned into a cellulitis. So like if somebody has seen a German shepherd pyoderma, it's basically a deep pyoderma. If somebody has seen a furuncles in the interdigital spaces, which the pus and blood oozes out, that's a example of deep pyoderma. And superficial is like, for example, hotspot is just general surface. Superficial is this bacterial folliculitis I was talking about. What do you do in case of the demodicosis with the secondary fungal? And okay, three things have come into the picture. It's okay, just treat demodex with these brevectors and sympatricas available in the market, and depending upon how bad is the fungal and bacterial infection, that's my first preference is always topical. Fungal, so mostly I just don't care. I feel like if I have controlled the source, it will go away. So I always prefer with the chlorhexidine shampoos, and this happens generally whenever you give like anything. You have controlled and patient has got a good immunity back. So just fungal go until or unless it's not a case of a primary dermatophyte, and that looks very different. What to do in case of the severe? I understand. I want to recognize a stray dog. We can't diagnose. It shows negative and make you any injection like takes the dog is fine for few days. Again, we are notching the same crusty dandruff lesion all over the body. Uh, it's such a big case. I would advise you to send me the case, because there are so many questions which I need to ask for this case before giving my diagnosis. So I think let's share this case over the email. I can help you with that. What are the common disorders in India? Everything is there in India, apart from the fancy breeds which we don't have. Everything is here. So even I earlier used to think that no, we only have parasitic, fungal, and bacterial, but no, we have everything over here. It's just that you have to diagnose. For how many days we should use steroids? Should the dose be kept the same, or should it be stopped gradually by taking? Steroid depends like for what purpose you are using, honestly. Like I think you must be aware about, like, it has immunosuppressive dose, it has anti-inflammatory dose. So if you are using for the allergies, it is on anti-inflammatory dose. If you are using for some autoimmune diseases like pemphigus, it should be on the immunosuppressive doses. And generally for the autoimmune cases, like, they stay on steroid for months, and it has the induction period, then it has the maintenance period. Induction period generally runs for 2 weeks to 3 weeks, and then slowly we go for the maintenance period. Obviously, like, if you have started on certain dose, we have to taper it like someday. It's not like that that it should be continued for months like that. No, there is a proper way to use the steroids. But yeah, depends like in which case you are using that. What is the antifungal treatment regimen? First is, like, be very sure that this is a fungi. Okay, like for example, in cats you can easily diagnose fungus, like, the dermatophytes. We have to be very sure that this is actually a fungal infection. It's just not like you have looked and you say, oh, I have seen that circular lesion, now this is fungal. No, that thing has to come positive. And honestly, if you talk about like looking at spores over the cytology, most of the times the spores are not visible. So that what we are seeing is actually the bubbles or the artifact. So that's why I'm telling you, let's be very comfortable seeing cytologies. Just don't rely on the cytologies. See by yourself and diagnose like this is happening or no. Go for the proper cultures to confirm, and then only say this is a fungal infection. Then if it is there, then topical shampoos are there, azole therapies are there. My big patients, like, if I have seen a cat, generally they respond very well to the azole therapy. So I have never used anything else apart from that. How do you manage the canine atopic dermatitis? That also a very vast topic. I think you should see a webinar. Even I think it's on YouTube, for the management of the canine atopic dermatitis. There they have explained in a very beautiful way, like how it should be managed, because that's not like a talk of 1 minute. It's a big debate. Would you biopsy through the crust or around it, and why? Okay. So, see, uh, whenever you take a skin biopsies, it should not always be like one. It should be a multiple, and from the multiple areas. So, like, for example, if there is a one lesion, and inside lesion, I feel like it's completely necrotic. So whatever sample you are going to take is basically necrosed. So what I generally do is I take one sample from the healthy skin. I take one sample from where the, like, half bifurcation, half good sample, half infected sample, and one sample from the infected area. And yeah, that's how I just like. And mostly I keep one pathologist with me, like, if he's comfortable with the size of the biopsy sample which I am taking, if he's comfortable with the sites from where I am taking. And another than that is in skin, I think uh, those who take biopsy samples are very much aware about, like, it should not be properly you can't disinfect that area, you can't antiseptic that area, you can't prep that area, because otherwise the lesion will gone. You only have to prepare that site, like, you just mark that site from where you are going to take the samples, and take a, like, full chunk. Okay, generally, like, if it's on the back, I take a 8 mm or 7 mm sample. So that's how I take the sample. Kindly advise how to recover in contact dermatitis. Just remove the source of the allergen. For example, one dog which I saw, like, he used to get the contact allergy over here. So he was having the allergy from his bowl. They were using rubber bowl, like bowl from where he used to take water, water bowl. So I just changed it with the steel bowl, and things recovered. Okay. In topicals, what is your line of protocols in product use? When do you shift to the oral? Do you first start shampoo or spray or oil? In topicals, I always prefer shampoos. Always, always, always. And shampoos are really good. And I honestly, if in any case like having a deep wounds or surgical patients, particularly because here whenever we do surgeries, then after that they have skin problem also. So they just tell me to now treat the skin infection. Then I feel okay when we are going to remove the sutures. Just tell me because I'm helpless. I just want to bathe this dog and he'll be completely normal. So I always prefer shampoo. But if any chance you can't able to like bathe the dog completely, you can bathe that lesions. Even that I do in like my allergic cases, because sometimes the whole body is not infected, so I ask the owner to bathe that areas with the medicated shampoos and the whole area with the normal shampoo, so that because these shampoos, the antifungal antibacterial shampoos, are dry shampoos, है ना? So why to get the whole body like in contact with those shampoos? You can bathe with the normal shampoo and bathe that particular areas with the infected shampoo. So generally, if you are using topical therapy, I generally wait for 3 weeks, 21 days, and if it's not working, then I shift to that. Or if it's not possible for owner to like go for the bathing every week because of any XYZ reason, then unfortunately I have to shift. But honestly, if the dirt is not washed from the body, oral is not going to work. Your dog should be or cat should be completely clean, then only you can think about, okay, now this thing is not working, now then I will go ahead with that. Hmm. Spot on. Ivermectin mostly use. I can you share your communication channel with my advice? We can communicate you. Yeah, I can share my email. There, you can ask me the questions. Uh, what is your take on homeopathic treatments? There is no homeopathic. Honestly, I'm not a good person to comment on that because I have never used homeopathic medications. And one time I tried, but it was not from the vet homeopathic. To be honest, it was like I was like seeking homeopathy because I was suffering from one disease, and then I thought let's try the same thing on dog, and I asked like make a prescription from the human homeopathic doctor, and but it didn't help. So I think if a proper veterinary communicated homeopathic medications we use, we can come up with the thing, like those who have the experience of using it, they are better person to tell you. I have never used, and hopefully if we come up with some the written literatures, then I can try and I can tell you better. How do you handle where the cytology show make for the dog is already on a therapy? If a dog is already on a therapy and still is having infection, then possibly that therapy is not showing effect against these infection. Or another thing is that the underlying thing is not under control. Okay, it's not like that your antibiotic or antifungal is not working against this bacteria and yeast. It means that the thing which is causing these bacteria and yeast to proliferate is not under control, so you have to control that. Okay, are there ayurvedic supplements claimed to be able, any thoughts? I have never used these supplements, sorry. in less than uh, in less than 3 months old puppy, I am very comfortable using those propoxer powder. I just take in hand and dab 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 and generally just slice go away. In dog with the mist, how do you prioritize treatment to avoid worsening one component while see mites will go away? Now mites is nothing, like you just use these isoxazolines and mites just go away. Then you have to manage the, because these bacteria and yeast is coming because of the mites. So mites, so now to, we are lucky that we have so many options available with us. We can manage that and this bacteria and yeast will go. Bacteria and yeast are just like friends, they come when one friend is there. They themselves don't have that much capability to cause thing. When something else is going on, then they get the opportunity to multiply. Okay, if I confirm demodex mite in 1 month old puppy, what treatment We do. Uh, it depends, like have you like properly confirmed in 1 month old puppy? Honestly, if the lesions like I think once I have seen like they got this from the kennels, so I just they're like topically just some creams or something I apply, and I just allow 2 3 weeks to pass, and then after that a very little dose of ivermectin I try, and generally it helps. And by the time they are 3 months old, then so we can use these the things which are available, but very low dose of ivermectin can be tried. The shampoos, what is a frequency? Frequency, I am comfortable using them weekly, but sometimes if the cases are very bad, then I use them twice a week also. Depends, like what is a frequency. And the thing which I'm talking about are the medicated shampoos. You can't like twice a week bathe a normal dog, okay? Then it will end up having a dry skin dog, and that is the invitation to another disease. Okay, so I'm talking about the infected dogs. uh, is gaining market. Oh, um sorry, Bexon's homeopathy. Thank you for letting me know, but I'm not like familiar with this company's name, but it's okay if it's coming, we'll try. But till the time we get a good literature, and if like people have conducted good trials, or like always being a like practitioner in a skin, I would suggest you that Google has everything, and Google has a good published literature. Like just see some literature and then you can start using the things. Like for example, if I'm talking about the chlorhexidine shampoos, then there is a dedicated literature for that. There is a published literature for that. So you get the confidence. Okay, it's not always like okay, this company has made one product, and since the time I am using, I am seeing a good results. Then you do study and publish that study so that other people are also benefited. So that is my like request, that always go for like what has been done in the market, so in the industry by the good scientists. Like people have spent years doing their researches to let us people know like what is helpful or what is not helpful. But and we have to uh, how can we join WhatsApp group where we can share? Yeah, you can become a part of this association, the IAVD association, Indian Association of Veterinary Dermatology. Every year we do the conferences, and where the diplomates come, like the specialists of dermatology. We are the just student, we are learning from them. So you can become a part of this association, and then you can get added into that group. And there are many people, like many experienced people will tell you ki, okay, if you have stuck with this case, what you can do. Okay, cytology. Cytology skills. Okay. uh, Honestly, when I used to, because in my case I didn't have choice, that was my research, है ना? And I can't make the pictures, I have to prove my case with the cytology and the biopsies. So I learned with the practice. I used to sit hours on the microscope and just see. Then I used to look for there is very good book. I just don't remember the name for the skin cytology. Then I used to look at the pictures for that. Then I used to look for my microscope, like what I am seeing, and slowly confirming with the pathologist whether I'm seeing right, whether I'm seeing wrong. I used to like little bit learn. Still I miss few things, but in skin whatever is required I can see. Yeah, cancers and all I can't differentiate, only 2 3 I know. But cytology, what you have to look for: bacteria, malassezia, any abnormal cells which are coming into picture, that you can like clearly differentiate if you are comfortable seeing that. And that only will come with practice. Okay. One dermatology that pays for itself the fastest. That pays for itself the fastest. I didn't understand dermatology tool. Thank you. Diagnostic triage order for. Um, This pruritic dog thing, I think Dr. Name is not coming to my mind. There is one lecture on YouTube from this association only. The Drools only have uploaded on YouTube, and Dr. Madhvi, she gave a lecture on the approach towards the pruritic dog, and it's an amazing lecture. I would advise you to just go through that, and you'll come to know. My take home message is that be comfortable, slowly, like start reading book, which is very important. And I won't tell you to go deep into the books, like just, and if I have shared my source, right? So if you go through that book, like just go through 3 chapters, like how to diagnose, how to treat, you know, and once, and like if in bacterial, what are the diseases of bacteria, just like randomly sit and see that book, you know, because otherwise it's like, for example, I whenever see any neuro case, I feel like I should run away from the room. Okay. So and similarly, doctors in my building, whenever they see any skin case, they just feel like to run away from this case. So I can feel you, like what feeling is there whenever a skin cases come. But it's just that we have to become familiarized with the cases, how the lesions look, how they are. Then slowly we'll start doing this thing. Okay. Are there any dermatology courses or internship programs for the same? Uh, Dermatology courses, we our plan is to come up with that, but for now we are doing workshops that you can join. These are also really helpful because they live demonstrate on the case. They lively will tell you, okay, this case is having this case is having this, and they will lively tell you, okay, how to read the cytology. So workshops are really good, so I encourage you to come for the workshops. How to become a member? um we that I think Dr. Nagarajan will let you know, है ना, that there is a like certain fee which you have to fulfill. There is a proper form which you have to fill, and then after that you can become the member. And do come to the conferences. There you get to know more people, and there you get contacted with the more people. And now the dedicated conferences are happening. Like this conference is going to be our 5th conference, you know? So yeah, this is really helpful. Workshops, about workshops, generally like on LinkedIn, on Facebook, we have page, everything is there. Social media only will help you know like these things are happening or no. But yeah, when once you become a member of this association, generally on our WhatsApp channel these things come. But otherwise I think people are so closely connected, they come to know somehow. I don't know. Sorry. So yeah, I think we are done.
Whoa, such an amazing session. Yeah, lot of questions, and you have beautifully answered. You have answered each and every question. I think malab, everybody would have enjoyed listening to the session. So yeah, unfortunately, we are coming towards the end of the session. On behalf of IAVD and Rules, I would like to thank you, Doctor, for taking time out, giving such an informative session. And thank you to all the doctors who have joined, who have given their time, taking time out on a busy Sunday from the practice. And I really thank you, Doctor. And I know all the doctors who have joined would have really enjoyed it. They would have taken a lot of takeaways. Not only one, I would say a lot of takeaways, live practical cases, and this will help all the vet community as a whole to upgrade their practice, to treat cases more passionately, more I would say more clearly diagnosing it. And I thank IAVD to organize such webinars, giving rules and platform to organize all these seminars. So yeah, thank you, Doctor. Thank you, everyone, for joining, and looking forward for the conference and upcoming webinars. Thank
Yeah,
you, Doctor. Yeah,
thank you so much.
thank you, Doctor. Thanks a lot. Thank you, everyone.
Thank you, everyone. I had a lovely time.
Same here. Looking forward. Yep.
friends and I, we talk about everything under the sun. So how can we leave out discussing something as important as our pets and their diets?
Always remember to check the back of the pack when it comes to buying food for your pets.
Make sure that you're feeding only real and clean ingredients.
It is 100% real chicken.
No byproducts
or fillers.
All natural, all healthy ingredients.
It gives them the best of both, taste and nutrition.
Drools.
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 Drools. Feed real.
Feed clean.